In today's episode, we will discuss the interceptive orthodontic procedures that is carried out when signs and symptoms of a developing malocclusion is evident. They are divided into the serial extraction of the tooth, correction of cross bites, anterior ones, controlling of oral habits, doing the stripping of the mesial and distal interproximal space of deciduous tooth, correction of occlusal interfaces, and space regaining muscle exercises, and removing any barrier to the tooth eruption. For the serial extraction, it is indicated in class 1 malocclusion when there is severe to moderate arch length tooth material discrepancy, which means that there is a crowding of the teeth, but we have a molar relation that is class 1. Also, if we have lingual eruption of upper lateral incisors, we do the extraction. If there is extreme labial displacement of the lower incisors, if there is altered eruption sequence of primary teeth, or any ankylosis of primary teeth. So, how it is performed? Serial extraction is a continuum decision-making process. It is not a single-time diagnosis. We must do an orthodontic study model, and if there was a discrepancy of 5 to 7 millimeter, then the serial extraction is indicated. Also, we must assess doing the caries analysis in the lower arch and an arch perimeter analysis in the upper arch. Also, the mixed dentition analysis helps in determining the space requirement for erupting posterior teeth. We may also take some radiograph, whether it is a periapical intraocular graphs, to see if there is any ankylosed teeth, or we can see the root development and assess the dental age, and to detect any bony pathologies we can do cephalometric lateral images to analyze the skeletal relationship and direction of growth. How it is performed, and there are several ways of serial extraction procedures. We will discuss each of them. First, the Doyle's method is a 3 serial extraction procedure. It starts with the extraction of the deciduous canines, then the primary molars, first molars, then the permanent premolars. How it is performed? We start up at the age of 8 to 9 years, and we extract the primary canines. This to create space for the alignment of the incisors. After 12 months, we extract the deciduous first molars, and we must see in the radiograph that the first premolar has reached half of the root length. This way we will accelerate the eruption of the first premolars. When the premolars starts to emerge inside the oral cavity, we will extract them, and we should make sure that before extracting the permanent first premolars, that the permanent canine has reached its half root length, and if it didn't, we must delay the extraction of the permanent first premolar. After the eruption of the permanent canine and the second premolar permanent, we can see that there is a proper alignment. In some cases, we may need a mechanotherapy of minimum duration, but it is not necessary in all the cases. The twins method involves the extraction of deciduous first molar at age of 8, then followed by the extraction of the first premolar. At the end, we extract the deciduous canine, and the reason is that we are preserving the space for the permanent canine by leaving the deciduous canine for the last. Also by extracting the first permanent premolar and deciduous molar, we are giving a space that is necessary to compensate for the difference in the size between the permanent and the primary canine. For the Grun's method, it is performing the serial extraction based on planning of each different clinical condition. For example, if we have a class 1 malocclusion where there is a premature loss of a mandibular deciduous canine, in this case, there will be a midline shift. So, and if we have seen that there was an early loss of a deciduous canine with a midline shift, and there is a discrepancy of arch length that is 5 to 10 millimeter, we should first do is to extract the opposing deciduous canine, and then we will extract the deciduous first molars, upper and lower. When the premolar starts to erupt, we will also extract it. But the rule is that before extraction, we should make sure that the tooth that will emerge has reached its root half length. Another case is when there is a severe mandibular anterior crowding. We should extract the deciduous canines to give space for the anterior portion. Then we should extract the first molars and wait for the premolar first molar to erupt and extract it also. The advantages of doing so is that it brings early self-induced alignment and improvement of overall oral health, but it needs patient compensation and a psychological acceptance that he will lose a total of 10 teeth if they were all extracted. Also, it is not indicated for class 2 or class 3 malocclusion. In some cases, we can extract in the upper arch of class 2. Also, it needs a proper time following, because if there is an early extraction, this can lead to an opposite result, and we will get loss of space and delayed the eruption of the permanent teeth. The interceptive procedure is the proximal stripping of deciduous tooth for the first or the second molar deciduous, often required to facilitate the eruption of adjacent permanent teeth into normal occlusion. So if we do a proximal mesial surface stripping of this deciduous tooth, we prevent the mandibular anterior crowding. Also, if we want a space for the canine to erupt, we can use a disc and start stripping of the second deciduous molar, which will lead to distal drifting of the first premolar, creating space for the canine to erupt. Now let's talk about the interception of crossbite. Crossbites have three types. They can be dentoalveolar, which means that they are confined with the tooth, or they can be skeletal, or they can be functional. If they are only confined with one tooth or some, the crossbite can be intercepted or by using what is called a tongue blade, where the patient puts it in the space between the two jaws and starts biting on it for 1 to 2 hours and repeats it for 10 to 14 days, and it is usually sufficient to deflect the lingually erupting maxillary incisors into its proper relationship. In some cases, we use an appliance that is called the Catalan's appliance with a Z-spring and a posterior bite plane. But if the crossbite is skeletal, we must use a myofunctional appliance, which is the Frankel 3 appliance, or an extra oral orthopedic appliance like the chin cup. But if it was a functional anterior crossbite, which we call it the ZEDO class 3 malocclusion, where the patient is forced to tilt the mandible in a non-centric position due to obstacle that is present, so we eliminate it by using a pear-shaped burr. Like in this case, we see that there is a functional class 3 when the patient is able to get back to its centric relation. It is the way to distinguish between the ZEDO class 3 malocclusion and the real class 3 malocclusion. So when we see that it is only a functional class 3, and it is due to an occlusal obstacle in the teeth, we remove it. We can do an interception of class 2 malocclusion that is a skeleton. We know that class 2 malocclusion is due to the maxillary excessive growth, and it can be intercepted by restricting the maxillary growth by using the face bow with head gear. But the interception of class 3 malocclusion, which is we should restrict the mandible growth by using a chin cup and headgear, or if it was a class 3 due to deficiency in the growth of the maxilla, so we use a Frankel 2 appliance to enhance the development of the maxillary arch, like in this case. Another way of interceptive orthodontics is the space gaining, using 3 types of appliances. when there is an early loss of the second premolar, a distal shift of the deciduous first molar happens, and we can regain this space by using a two finger springs, one on the mesial of the first permanent molar and the other is on the distal of the first deciduous molar, and we use retentive Adams clasp on the molar of the other side and the anterior teeth. Then when activated, we regain this space. Another method is using the jack screw. Instead of using the spring, we use this screw, and when it is activated, it acts at the same in the same manner as this one. The Gerber space regainer, it is a seamless orthodontic molar band that is selected for the specific tooth to be distilled, and it consists of a U-shaped hollow tubing. This is how it is made. Also, we can do what is called the muscle exercise. For the masseter, we can ask the patient to clench the teeth and count for 1 and 10 and repeat it again. For the pterygoid muscle, we can make the patient protrude the mandible, then retract it and repeat it until he gets tired, and this will make the mandible develop to its correct position. Also, the last interceptive procedure is the removing of any soft tissue that covers the crown of an unerupted tooth to create a space so that the tooth can erupt without any obstacle. That's it.